Hi, how are you today? As you can see, I'm sitting in my kitchen, so we'll just ignore the background if you will. My name is Mike Fritz. I'm a cardiovascular specialist, and my area of expertise is cath lab, electrophysiology, and in the past I've done interventional radiology and neuroradiology. What I'd like to talk to you about is the field of electrophysiology. It's relatively new for medicine. It's only been around for 25, 26 years and only really come into its heyday in the last 8 to 12 years. Technology has caught up with our thoughts of what we could and could not do within the human heart. We can treat anything from SVTs to reentrant rhythms to any of the malaise from tachybrady syndrome or sick sinus. So in essence, if you have a rhythm disorder within your heart, we can either fix it or implant a device which will control it. All of that having been said, we're looking at doing simple ablations, radiofrequency ablations of SVT, supraventricular tachycardias, which part of those are AV-NRT, AV node reentrant tachycardias, AV-RT, AV reentrant tachycardias, AV nodes, ablations to eliminate persistent flutters and fibs, and we can do flutter ablations on the right side and fib ablations on the left side, PVC ablations in the outflow tracts. All of these things will eliminate almost all arrhythmias. Wolff-Parkinson's White can be dealt with as a bypass tract ablation. We can cover most of the maladies of arrhythmia. One of the most prevalent forms of, or causes of arrhythmia in women between the ages of 11.5 and 48 in puberty and menopause is birth control pills. Simple fix for that is to change the birth control and the rhythms go away. Wolff-Parkinson's White has been around for quite a long time. It's very prevalent in blacks more than whites. However, it is now becoming much more widely spread, depending on your side of the fence as to whether you think this is caused by better diagnostic tools, or what is the reason it's showing up more and more in both sexes and in all races, creeds, religions throughout the world. It is relatively a debilitating rhythm. The heart rate accelerates into 200 and 300 beats per minute. Your heart can't pump blood at that rate sufficient to keep you upright, so you pass out. We can go in, find the bypass tract, whether that be left-sided, right-sided, or a little bit of both, because more than 40% of the time there is more than one bypass tract. So we have to find the first one, kill it, and then look for the second, third, fourth, fifth, sixth, however many there are. Reentrant tachycardia is very simple, very straightforward. They're going to be spinning around the AV node, the compact AV node, and we just simply take out the leg and it can't go anywhere. Flutter ablations, 99% of the time, they're coming through the bottom lateral wall of the right atrium, across the isthmus, up towards the CS, and we just ablate the isthmus line, and that bridge is blown and the circuit can no longer be maintained, so flutter is cured. A lot of times we will have flutter that is actually atrial fib, that is left-sided, and it's driving across and masquerading as a flutter, right-sided. So we will take out the flutter and then find that we've got fib, and then we'll go transeptal, which is poking a hole through the foramen ovalis, or going retrograde up over the arch and down into the left atrium that way. And either way we can get the pathways and eliminate the rhythm. VTAC usually is a very, very, very sick patient because they're having ventricular storms, so their ventricles are just fluttering. They're extremely debilitating and are lethal. We usually go in and start killing any focus that we see that is causing aberrant ventricular contraction. The more we get, the faster they'll stop having the storms, and we'll be back to health. PVC ablations are extremely time consuming because you have to find the single fiber that is causing the multiple PVCs, which are debilitating also. And usually they're in the outflow tracts, and we can go in and ablate them. New technologies for doing atrial fib left-sided is cryo balloons, where we actually freeze the tissue at -70 Celsius, so that's iceberg time. The good thing about cryo is with the Arctic Front balloon we can do half, quarter, or the whole circle at one time of the pulmonary veins. We have to isolate all the veins. The good thing about the Arctic Front also is that you can pace, sense, and freeze all from the same device. It's a massive step forward in technology. So pretty much what I'm telling you is if you have any arrhythmias, whether that be a fluttering in your chest or a debilitating rhythm such that you can't even stand up when you have it, that you pass out frequently, come see a cardiologist, ask for electrophysiology consult, come see us, we'll find it, we'll fix it, you'll be back on your feet. Okay, enough from the kitchen. Y'all have a good day.